Morning everybody. So today we are going to have a class on the diseases of the breast. This is Dr. Amrit Kaler, Professor of Pathology. Before we get into the diseases, we should know the anatomy of the breast. The breast is made up of milk producing glands. It is basically a sweat gland, you should know. And it rests on a pectoralis major muscle, and there are three different hormones which affect the function of the breast: estrogen, progesterone and prolactin. Now, in the anatomy which you have read in the normal anatomy class, I'll just repeat: the breast consists of 15 to 20 lobes, okay, and each lobe will have different lobules inside it, and they will secrete milk which will be collected by the ducts, and the ducts will drain outside from the nipple. Now there are four quadrants, as we know: alveoli, lobules, to the lobes, and then it goes out. The four quadrants include the upper left and the upper right, lower left and the lower right, and then we have the space which is known as below the areola. So we have four quadrants in the breast by which we define the different location of the different tumors inside the breast tissue. So now these ducts and the lobules, they are lined by glandular epithelium, and they are supported by a fibrous stroma or a supporting structure which is known as fat. And the Cooper ligaments is the one which supports the breast tissue and which connects the breast tissue to deep facial layers. Now this is the one which I have discussed with you always: upper quadrant, lower quadrant, and then we have the medial and the lateral quadrants, and then we have the tissue below the areola. Now if the example of this is, if there's a malignant tumor at 3 o'clock position, right breast, so you know where it is, okay. 3 o'clock means the medial side of the right breast. So this is how we define that the lower inner quadrant or the upper inner quadrant, or the medial or the lateral quadrant, are the ones by which we define the location of the tumor. It is supplied, the breast tissue is supplied by the internal mammary artery or the lateral thoracic artery, and then we have the venous returns and lymphatics, which is not very much required in pathology until you see the tumors of the vascular tissue, like an angiosarcoma, which is very, very common, a malignant vascular tumor which we see in a breast tissue. So lymphatics, we have three levels of the lymph nodes which can be seen: lateral to the pectoralis minor muscle, and level 2 which is under the pectoralis minor muscle, and level 3 is a medial. So internal mammary chain is the one which drains it, and we have the nerve supply by long thoracic nerve, thoracodorsal, medial pectoral, and the lateral pectoralis nerve. So what do we derive from this lecture today? We are going to discuss the etiology and the pathogenic features of various non-neoplastic and neoplastic breast tissue. So today it will be most commonly non-neoplastic breast tissue. So at the end of the lecture, you will be able to define about different risk factors and the etiologies and different types of breast cancers. The clinical presentation is the palpable lump. In any of the breast tumors, there will be a lump in the breast, okay, and then this lump, we have to diagnose it further to call it as a benign or a malignant, or it can be a little inflammatory mass which happens secondary to the breastfeeding. The nipple and the breast tissue gets infected out of it. Then we have a nipple discharge, which is blood in color, which is seen in the papillomas. Then we might get the fibrocystic diseases, which presents themselves as non-palpable abnormality. So what is the method of diagnosis? We do have FNAC, we have incisional biopsies, we have excisional biopsies, we have image-guided biopsies. All right. So these are the different ways in which we diagnose, and we practice all this in our institution. Now let's talk about the benign breast diseases, in which we have, first one is the inflammation. Inflammation is the acute mastitis. This is the most clinically important form of mastitis. We have the cracks and the fissures, sometimes while feeding, and these cracks and fissures will be superadded by the infections like Staph aureus, which are the normal commensal in the skin, and these will infect the nipples, and they might get inside the breast tissue, which causes the acute mastitis, which is quite painful. Mastitis is quite painful, and it is mostly unilateral, and this might lead to an abscess formation. So treatment is, first treat them with antibiotics, and if it doesn't go away, you'll have to drain the breast tissue. Then we have this periductal mastitis, in which there is a infarction, or there is a subareolar abscess which leads to the squamous metaplasia of the lactiferous ducts, and there is a painless erythematous subareolar mass. 90% of the smokers will lead to it, and these will have the lactation, reproductive age. This might happen in this age when the patient is young, or there is a fistulous tract which is formed secondary to any sort of infection. So this will lead to the periductal mastitis. So microscopically, because of the infarction, we will be able to see the squamous metaplasia of the nipple ducts. Okay, and then there might be a keratin which will be shed into the ductal system, dilation and rupture of the ducts. Then we'll have the chronic and the granulomatous inflammatory response, and then a secondary bacterial infection might supervene. So what you will see, you'll see lymphocytes, and you will have the granulomas on microscopy, and if it is severe bacterial infection, you might see some neutrophils as well. Now, under the inflammation, we have the mammary duct ectasia. In this, there is again a periductal inflammation, chronic inflammation with fibrosis, and this doesn't happen in the reproductive age group. This happens in the 5th and 6th decade, and it affects only the large ducts, unlikely the periductal mastitis. So what happens is poorly defined periareolar mass, and they will be clinically confused with the carcinoma. This is where the other diagnostic like incisional biopsies might come into picture, and that maybe we might be able to rule out that this is not a carcinoma. So they may present themselves as a cheesy or a thick nipple discharge, and you may see a periductal fibrosis or a skin retraction. Alright, so this was mammary duct ectasia. Then we have fat necrosis. This might happen secondary to trauma. Very commonly, sometimes after the fall, you might experience some sort of pain after the trauma, and then it might lead to a painless palpable mass. There might be a skin retraction, but what will happen on microscopy, there is a necrotic fat tissue with the macrophages, lipid-laden macrophages and neutrophils in that particular area. So they usually come as ill-defined white nodules, and the patient will say he fell down or she fell down sometime later, and this has formed gradually now. So we do the microscopy, or we do a FNAC or an incisional biopsy, and we see chronic inflammation with continuous giant cells, and they can also be confused with the carcinomas, because sometimes because the increased fibrosis and calcium deposition, it might lead to the confused diagnosis of a carcinoma. So that's why whenever you call a carcinoma, you have to rule out all the important non-neoplastic conditions. Okay, so the next very, very common disorder which we see in women is a fibrocystic disease. It's the most common breast disorder, and this happens as the women grows older. The cysts might be formed in many women, and also the PCOD might lead to formation of some cystic change in the breast. And this usually happens because of the hormonal imbalances in the patients, but the risk of progression of cancer is less. You cannot say no, but it can be 3 to 5% of the chances in the late age might lead to the carcinoma. Now, what are the pathological findings? You might see a cystic change. You might find a cyst on palpation and also on ultrasound. You will see microscopically epicrine metaplasia, adenosis, increase in the number of glands, and then fibrosis. Alright, so in the cystic change, there will be small cysts which is dilated, and you might see a turbid fluid inside them, and that turbid fluid may come out sometimes from the nipple as well, but they will be lined by an atrophic epithelium or an epicrine cells which will be lining these cysts, and the calcification can also be seen inside them. And there is an adenosis, an increase in the number of glands. Now you can see this is a cyst here lined by flattened to a little bit of 3 to 4 layered, and on a real high power you might be able to see some sort of epicrine change in this lining epithelium. Now over here you can see there's an increase in the number of glands, and there is adenosis here, and few of the glands are still getting dilated and they may dilate it further. Now this is a classical picture of an epicrine metaplasia. You see all these cells, they have abundant cytoplasm with the abundant granular cytoplasm, and this epicrine changes because of the presence of the mitochondria. And you can see in the lumen of these glands, you are able to see some of the fluid along with the inflammatory cells, scanty inflammatory cells. This is a beautiful example, and the fibrosis is seen in between these cysts. All right, now what is a fibrosis? Fibrosis is formed secondary to the cyst rupture, release secretions into the adjacent stroma because of the chronic inflammation and fibrosis, and there's a palpable mass of the breast. Now adenosis, as I've shown you the picture, what is adenosis? It is nothing but the increase in the number of acini per lobule. You have seen this before. There is lobes, then we had lobules, and then we had acini. So in a lobule, there's an increase in the number of acini. So this might happen in the pregnancy, this might happen in the fibrocystic disease. The acini are enlarged. In blunt duct adenosis also, we are able to see an increased number of acini and calcification, and they may be lined by columnar cells, benign or atypical features. Now this entity is a newly diagnosed entity, and you might call it as columnar cell metaplasia, which is a new name for blunt duct adenosis nowadays, and they may be benign or may show some atypical features depending upon the number of the lining epithelium layers. So you just need to see whether it's lined by a single layer or 3 or 4 layers. So depending upon that stratification, you can say it is a benign or suspicious. Now, this fibrocystic disease, they are usually reproductive age group because of the change in the hormones. So you might see a palpable lumps or a nipple discharge or a mammographic densities or calcification, and they might be multifocal and bilateral as compared to fibroadenoma, which is which usually presents as a lump in the breast, but they may be single most of the time, or they may be multiple as well, but this is more like a lumpiness. It looks like a lump, but it's not a lump, so it's multifocal and bilateral. So also, other than the fibrosis and the cystic change and the adenosis, you might be able to see epithelial hyperplasia. Now, hyperplasia, which I've already discussed, it is stratification, increases the number of layers of the cells. Now you can see each of these ducts, they are lined by more than 4 layers, more than 4, these are around 8 layers. So this lining epithelium, the upper one, might look like 2 to 3 layers, and they are showing some apical snouts over here, which may point out towards the fibrocystic disease. So they may be overlapping the lining epithelium stratification, and they may be proliferating cells. Now you have to be very, very discreet in diagnosing these cases, because they might get into atypical hyperplasia or DCIS later. So you have to follow up these patients when you see such amount of hyperplasia. So the proliferative diseases without atypia are the few of the conditions in which we call it as sclerosing adenosis, and we have the acini, increased number of acini with fibrosis within the lobules associated with the calcification. Then we have the atypical hyperplasia, characterized by atypical architectural or cytological features, in which you start seeing atypia in these ducts and also in these lobules, ducts situated inside the lobules. Okay, so atypical cells might resemble the DCIS, but if they are atypical, the chances of malignancy, you say that's around 10% if you say atypical hyperplasia in these cases. So you have to do marker testing of ERPR, HER2-neo, and other E-cadherin and Ki67 to rule out any chances of malignancy in these cases. So atypical hyperplasia is an alarm, particularly in fibrocystic diseases if it is present. Now let's talk about the benign tumors which are present inside the breast. Number one, which is very common, is the fibroadenoma. This is a circumscribed lesion. When they say it's a most common benign tumor, you call it as a fibroadenoma. When it's a most common, the disease of the breast, then it is called a fibrocystic disease. So this is how we differentiate. And what is a fibroadenoma? It is commonly known as a lump in the breast. This swelling, whenever you try to palpate it, it will just escape from your hand and it will just rotate inside the breast. So they say the lump in the breast, which is highly mobile, it is not fixed to the surrounding structures. So it is a circumscribed lesion, and it will have the proliferation of both the glands and the stromal elements. On the gross, there are spherical nodules, size is less than 1 centimeters, and they can be a big, huge, about to 10-15 centimeters in a juvenile fibroadenomas, which is very common in the adolescent age group. So they will be mostly grayish white, shiny white, or sometimes grayish nodules, and it bulge into the surrounding structures, and they will show the slit-like spaces on the gross as well, and on they might show a myxoid or a stroma or the fibroid stroma, depending upon what predominance, and the epithelium will be surrounded by the proliferated stroma. So what happens is, this is the gross you have seen, and this is the microscopy. It will have two types of patterns, pericanonicular pattern and an intracanonicular pattern. Pericanonicular pattern is the one when the ducts are compressed by the fibrosis. And you can see here that there are ducts and also there is a stroma. So you can see the acini, which are enlarged, and they are a little dilated, and there is an increase in number of cells. And then we have the stroma. The stroma is showing fibrosis here. So, and it is a well circumscribed. You can see the surrounding breast fatty tissue is being sharply circumscribed by this fibroadenoma, this tumor. So it's basically a benign tumor. It has chances of getting into malignancy is very less than 0.1%, but it is presents less than 30 years. It doesn't present later than that. If it presents, then it might change into a carcinoma, but it's not a fibroadenoma. So giant forms has been seen, I've told you about the juvenile fibroadenoma, and it is diagnosed basically on the size of the tumor, not on any microscopic features which helps them to differentiate. So they can be associated with other microscopic features, and if it shows a cyst of larger than 0.3 centimeters and it shows sclerosing adenosis, now we know what is sclerosing adenosis. The epithelial calcification and epicrine metaplasia, we call it as a complex fibroadenoma, and the chances of malignancy in this complex fibroadenoma is around 5 to 7%. So you have to understand the microscopic features very classically. Then we have another benign entity known as a duct papilloma. Just to close in fibroadenoma, it gets healed once you just do the excision biopsy. It is completely healed. It's not a malignant condition. The next one is the duct papilloma. Papilloma, it is a benign epithelial tumor, and it affects the larger ducts. It has a fibrovascular stalks on microscopy and surrounded by the proliferating epithelial and the myoepithelial markers. So most commonly they present with a serous or with the bloody nipple discharge. So papillomas, they are basically multiple branching fibrovascular cores. They have connective tissue lined by luminal and myoepithelial cells, and they mostly grow in the larger dilated ducts, and they are situated in the lactiferous sinuses. Small ducts are multiple and are located deeper. Now you can see this is a dilated large duct, and it is surrounded by a stroma, and the proliferation of the lining epitheliums is there. The vessels will have a fibrovascular core, and probably these are the cores here. You can see the central cores, blood vessels. Cores are nothing but the blood vessels, and they're surrounded by the epithelial cells, and they are quite proliferative in this case. So these globules, these ones, they are pale hyaline globules. They look like collagenous fuels to me right now, and if presence of these fuels also lead to a little more indication of turning into a malignancy later. So we have lots of not only clinical but lot of microscopic features which often tells us about different chances of malignancies later. So the pathological report is very, very important in these cases. So so this was about the duct papilloma. So it has to be removed it's by excision biopsy, because then the chances of malignancies, if you see such features or histological features, then you have to suggest the clinician to do excision biopsy, or if there is a presence of papillary carcinoma, because papillary carcinoma arises from the papillomas, then we might see a papillary carcinoma here. So if that is there, it has to be treated adequately. So I'll discuss about the papillary carcinoma in my next class on malignant breast tumors. So phyllodes, this is the second common tumor, benign tumor, which can be seen in the breast tissue, but phyllodes has been seen in the malignant format also, and I've seen many cases of malignant phyllodes as well. So a phyllodes basically means a leaf. So on microscopically, the tumor looks like a leaf. It gives a leaf-like configuration. So it's basically a stromal tumor, which is proliferation of the stroma, not the ductal cells as you saw in the fibroadenoma. There is a proliferation or the hyperplasia of the ducts and the acini. In the phyllodes tumor, the epithelial cells do not show proliferation, but the stromal cells, the stroma of the breast tissue, shows a proliferation, and which compresses the ducts and the glands, and which leads to a leaf-like configuration. It occurs at any age, and it can be from few centimeters to massive lesions depending upon how long they have been present inside the body. So they are basically low-grade lesions, but they reoccur, and because they reoccur locally, so excision biopsy is not enough for them. So you have to remove the surrounding breast tissue also. Extended excision has to be done in the cases of phyllodes tumor, because they might reoccur. So that is the treatment of option for phyllodes tumor, unlike fibroadenomas in which you just remove the lump, and that's the treatment. Here you have to do an extended excision in phyllodes tumor. So the low grade, they just reoccur, do not metastasize, but the high grade have shown malignant characteristics, and they have metastasized to the distant sites. So what you see on a morphology, presence of nodules of proliferating stroma covered by epithelium, and differentiated on the basis of cellularity, how cellular is the stroma, how much is the mitosis, and how much is the nuclear pleomorphism, stromal overgrowth, and infiltrated growth. So it's very, very classically you see on a microscopy the cellularity of the stroma, not the cells. Remember that we are talking about the stroma. This is a stromal tumor. So you will see the spindloid cells showing pleomorphism, and they will be plump, and you will see the mitosis happening inside the stromal cells. And if there is a stromal overgrowth around the glands, that is a very highly characteristic of the phyllodes tumor, and the infiltrated pattern into the surrounding tissue also can be seen. So of course there's a metaplasia which is also associated with the phyllodes tumor. You can see metaplasia into osteoid and chondroid depending upon the high grade and low grade, that you can always look into it. Okay, so the treatment is excision with the white margins, such as I told you, extended margins with the white margins, and the incidence of nodal metastasis is small in this case. And you know how sarcomas, they metastasize. I'm sure I won't be able to get the answers right now, but you should know how does the sarcomas metastasize and how does the carcinomas metastasize. Carcinomas metastasize by the lymphatics, and the sarcomas, they metastasize by the vessels, by the capillaries and the vessels. So that is why there is no nodal metastasis. So lymphatics are not involved. So what is the relative risk of invasive carcinomas in the breast lesions? I think I have already discussed, but there is no risk in mastitis, ectasia, fat necrosis, and the fibrocystic disease unless it has a proliferative lesions. But there is an increase, it's written 1.5 to 2 times if there is a presence of sclerosing adenosis or florid hyperplasia, fibroadenomas, and duct papillomas. But if there is an atypical ductal hyperplasia or a lobular hyperplasia, the risk is 4 to 5 times. So these are the statistics that they usually ask in the exam, even in the viva. So you have to understand this part and learn by heart. So this was all about the benign breast pathology. So about the carcinomas, now we will discuss in the next class. So till now, you please read the Robbins. Robbins is a very classical book which gives the descriptions very nicely. So all the best and see you in the next class. Thank you.